All right, let's try that again. So, welcome everybody. My name's Nigel Giam. Still more people coming in. I'm the lead GP training program director for St Mary's Scheme. So, I've been a TPD for 18 years. I've been teaching for the MRCGP for well over 20. And actually, tonight we're going to do something special, quite different from the webinars that have run before. Some of you have met me before. Some of you will be resitting this exam. Some of you will be taking it imminently. Some of you will be taking it later in the year, but it's going to apply to all of you. So what we're going to be doing tonight, a quick intro, a couple of polls just to see where you're at with this. We're going to run through 8 specific top tips. So this is quite a different webinar from what's run before to really maximize your success in the SCA. And then tonight we're going to be doing an active case calibration with one of my GPST registrars who I've been mentoring, and then we're going to be talking about some Q&A, maximizing marks in 3 domains. That'll be an open forum, as well as any specific cases that you have that you'd like to talk about, and then really consolidating with the SCA blueprint, and then some special offers as well. A few ground rules as we move forwards. Use the chat function for any questions. I'm recording this webinar. I hope to have it up on YouTube if it records successfully so that you can revisit it. Just a lot of constructive discussion tonight, please, if that's okay. So I suppose this webinar comes with a little bit of a hazard warning, which is that you're going to have to decide quite quickly what you want to believe. I know some of you are resitting this. I know some of you are going to be taking it imminently in the next week or so, but you will have to decide what you want to believe to pass. You don't have to believe me. This is just my opinion as to how to pass the exam. But let me tell you why I suppose my opinion might matter to you. And before we do that, we're just going to run a quick poll. I'd like all of you to answer, please, which is really what you feel the SCA might be testing. But before we do that, whether you feel the SCA actually reflects real life consultations. So I'm going to launch the poll, just a bit of fun, really, as an icebreaker. Please answer right now. So, do you feel that the SCA reflects real life GP consultations? Yes or no? Very simple. I'll stop the poll at around 90%. 44 of you have answered. If I could get a few more, that would be great. Thank you. We're at 88%. We're at 90%. That's fantastic. Let me just end the poll there. I'm just going to share the results with you. That's very interesting, isn't it? I mean, the majority of you, 60%, felt that actually the SCA does not reflect real life GP consultations. And you know what? I actually agree with you. It doesn't, because real life, encompasses patients who are not standardized. Whereas the SCA is standardized, so applies certain rules. And also, the sorts of consultations that you get in the SCA are not very typical of real life general practice. But at the end of tonight and this webinar, hopefully, I can showcase how you can use some of the skills I'm going to teach you to apply those to real life consultations and maximize your SCA marks. So, thank you for doing that. I'm going to run another poll, if that's okay, which is really to see what you think the SCA is testing. Before I do that, let me just get a few more people in here who are just waiting out in the waiting room. So let's run this. What do you think the SCA is testing? Now you have to choose the top 4 things that the SCA is testing from this list. I'll give you about 45 seconds. Got another 20 seconds or so on the clock. Let's try and get it up to 90%, guys. Everyone needs to answer because you're all doing this exam, aren't you? So can we get a few more people answering? That'd be great if we can. Okay, I'm going to stop the poll there. And I'm just going to share the results with you. So the overwhelming majority of you felt that this was about communication skills, risk management, negotiation skills, and then actually came in fourth, diagnostic acumen. Actually, what I would say to you is that Above diagnostic acumen and up-to-date guidelines is narrative-based medicine, and you'll understand why this is the case in a little bit. Okay, well, that's great. Thank you so much for participating in that poll. Let's move forwards. The SCA, unfortunately, has not had a great pass rate, as you can see from this slide. It has a much lower pass rate compared to what has preceded it in terms of both, the RCA and the CSA. So we've had just over a year of academic sittings of the SCA, and the pass rate's not surfaced really above 70% for a long time. It sort of retails around 68%, which is actually quite a lot lower compared to the CSA, which was around 75%. And there are reasons for that because this is essentially an assessment of how you deal with situations as opposed to symptoms and diagnoses. And we'll showcase this as we move forward. Now, everyone falls into this trap of thinking, you can just go through the motions of asking questions in a way. And I fell into this trap a very long time ago. I qualified as a GP in 2003, so it was a long time ago when the MRCGP wasn't a compulsory exam. It was an exam that was deemed of excellence, an exam if you wanted to become a trainer, and I'd, waited a long time, trained a long time to do this for over 2 months. And I thought my videos were up to scratch when I did the old RCA, but it was clear when I went to a college course, I was told in very black and white terms, it's clear you're a very nice GP, but you're clueless as to what the exam's testing you on, which left me somewhat distraught because I only had about 10 days to get my act together. And I realized some of you will only have 10 days to really get your act together as well. But that's okay because you can work smart with it. You can still get battle plans together. So I was able to do that and I passed. I passed well with a distinction. But I felt there were so many mixed messages. And unfortunately, there are so many mixed messages out there right now. And you will have to decide what you want to believe. I ended up working for the RCGP as a faculty tutor, ultimately as a course director alongside other active examiners such as Roger Neighbour, who's obviously still kicking around. But I decided to leave in 2007 because I felt this could be done better, more strategically. The sole purpose of these webinars and the SAA Masterclass is to get you through this exam with strategy. You will have to decide what you want to believe. There are so many mixed messages out there. In the era of the CSA, we had to examine, about 6 to 7 patients. And so, physical examination had a part to play. Physical examination has no part to play in this exam. So if you're someone who's risk averse, if your history alone only allows you to say, well, I need to bring you in for an examination, do some investigations before I commit to anything, it means you failed the SCA because there's no case in the SCA which is designed in that way. Your history alone should allow you to commit to risk and manage uncertainty with confidence. It doesn't mean you can't bring a patient in for examination, but if you are someone who is hiding behind an examination or investigation, you cannot, unfortunately, pass this exam. So, what is this exam about and how does it test you? Primarily, there are several ground rules which are very different compared to what is preceded. You have to know how to case prime, and case priming is about knowing your place in the patient's journey. So, for James Dillon here, you would always be asking why. In order to pass this exam, you've got to ask yourself, why? Why am I being told that this patient had COVID? Why am I being told they had migraine? Why am I being told they're not on any current medication? So if the patient comes in with a headache, you want to be using this information really quickly. You know, I can see that you've had migraines before. Do you think that this is also a migraine? You want to be eliciting a patient's ice early on. You see, what works in your favor in this exam is it's standardized. So every standardized simulation will have some ice built into it, if not all three components. And all you need to do is be invested in that and use it to shape the way in which you ask a history, to be patient-centered, not doctor driven. If you are someone who is just chasing a symptom in this exam, unfortunately, it will not end up in a good outcome. And we see this a lot. By the end of tonight, there are literally 5 things that I want you to take away. The concept of case priming, predicting what's going to be coming in through the door by mapping what you have been given to an SCA blueprint and a battle plan. I'll teach you one of my mantras tonight. There are three consultation mantras that I teach on my course, but I'll teach you the most important one. And this is about how you work smart. This is not about doing case after case after case. Okay. And it's also about calling out bad behaviors in your study groups, which I'm going to talk about in a little bit more detail. This is a very attainable exam. We are the only course to give score prediction based on your performance. And our score prediction accuracy rate is about 90 to 95%. I've been teaching for this for well over 20 years. And I just want to share a little bit of this with you tonight as to how to be someone who can score well. We specifically specialize in top scorers. A top scorer is someone who scores over 100 in this exam. And, we're very proud to say that these webinars and the associated masterclasses have seen over 1,300 candidates very successfully, a lot of IMG graduates as well, first time through this. So it can be done. So don't lose hope. Okay. If you're an IMG, I know there are many joining us tonight. You can absolutely do this, but you will have to change your battle plan, and it may have to change after tonight. And we specialize in a lot of top scorers with issues around neurodiversity, dyslexia, ADHD. You have to have a game plan here. You just can't go through the motions of going through case after case. And if you are taking this imminently, can I really advise you that actually you won't achieve very much right now just through doing practice through case books? If you're practicing the wrong way, you're better off watching what people have done to maximize their marks in the three domains and their battle plans. So Attar, who was a top scorer, had to get this done in a couple of weeks because he was getting married. He came on the masterclass. We did some very intensive one-to-one, and he was the master of case priming. We'll have a look at his case breakdown in the Q&A a little bit later. Faisal, I mean, if you just have a look at his face, you have to play to strengths. He was so very nice, but he recognizes that relating to others isn't just about being nice. It's about really good negotiations. It's about recognizing that you use your niceness to say no, to be nice, firm, and fair, and find a compromise. And if you're someone who's resitting this, let me reassure you it can be done, but you cannot go in with the same technique. There will have to be a 180-degree turn in how you approach this and do it right. So this trainee from Croydon, Rumby, very challenging for her. She'd done the AKT 4 times, so she was at her tether here. But she smashed the SCA first time with 107, despite having dyslexia, despite having a lot of issues from a personal perspective. So this can absolutely be done, but you must have a battle plan. And we'll talk about this as we move forward. So when we start looking at the marking schedule, and all of you hopefully will have had a quick look at the mark sheet, you'll recognize obviously the three domains. The clinical management domain carries 1.5 times more marks compared to the others. And on the masterclass, we rate you in each of the three domains if you're an active participant between clear pass to clear fail. Clear pass is a 3, pass to 2, fail is a 1, clear fail is a 0, and then I will rate you overall as the examiner will do between pass to bare fail. And by doing that and being very objective, we can give a score prediction. When we start thinking, I suppose, about the actual mark sheet, I just want to draw your attention to these competencies highlighted in red. Specifically, these are the ones that I see at ARCP that aren't done very, very well. You can see that case priming is a big thing, and we're going to do a massive group exercise breaker in case priming in a second. Because if you don't case prime, if you're just looking at the information going, oh, I wonder what this is about, then you're not going to do very well. If you look at the information and go, why am I being given this information? How am I going to map it to a blueprint? What are the challenges that are about to come through the door? Then you're going to do very well, because that will then maximize and prioritize the way in which you gather data, and essentially you'll get to a decision-making process a lot earlier. If you are someone who's risk averse, there'll be a tendency to over-investigate, over-refer. You may not actually manage uncertainty with confidence. And actually, the information that you're giving, are you actually recognizing why you're given that information in terms of comorbidities? And then relating to others isn't just about opening ice, it's about using it to center your consultation on the patient's agenda, readdressing it. And ultimately, if you're going to say no to something through negotiation, you need to take ownership with what you're going to do. Safeguarding comes up quite a lot, and just think about those other team members that can help you, your social prescribers, your allied healthcare professionals. So let's break this down. If you have seen the SCA mark sheet, you will see that all of those behaviors, as I've just showcased there, are summative and negative. That is to say, every time you're demonstrating a negative behavior, what's actually happening is you're getting marked down. So ask yourself this. In your study groups, are you simply going through the motions of going, hey, just some routine lifestyle questions? Do you smoke? Do you drink? What do you do for work? Who lives with you at home? Because you don't actually get marks, you actually lose them. Okay? Now, are you calling out those behaviors in your study groups? Because I can bet you 100% you are not. And if you are not calling out those bad behaviors with some tough love, then all you're doing is colluding and consolidating those bad behaviors. You have to call those out. And I get it. It's not an OSCE, but that's what we've been clinically trained to do. Clinically trained to ask those questions. This is not a clinically driven exam. It's a narrative based exam. But the problem is when you're clinical, you don't acknowledge. What you do is you process. And all of us have processing words, okay? Filler words. Okay, fine, right, sure. I'm so worried about this headache, doctor. Okay, fine. Yeah, but it's not okay, is it? It's not fine. As opposed to acknowledging the emotion, empathizing with the situation, and energizing with how you move forwards. This is all about transference. All of you said that this is about communication skills. This is not about what you say or how you say. I have hundreds of STs who failed this exam who come to me saying, I said the same thing as my friend and I failed and he passed. Oh, you said the same thing, did you? I'm sorry. No, you're not. As opposed to, I'm sorry. Or maybe you are. It's your tone, it's your timing, it's not just what you say, it's how you say it. So we teach a very powerful skill in the masterclass, AEE, acknowledge, empathize, energize, anything that's emotive. Rather than saying okay or fine, acknowledge the emotion that's in front of you. I can see that you're concerned. Be interested in that cue. The cue is the king queen of the consultation in the SCA, but cues are only given twice. And we'll talk about this in the top tips. And then energize. What can you do to help? Because if you don't do that, you're going to be talking at the patient, not with the patient. This isn't a typical clinic, so you're absolutely right. This is not reflective of the sort of things that you would see every day. You're going to have patients who really push you. Those of you who've been through this before, and I know many of you who are attending tonight are resitting, this was not what you expected it to be. You're going to have your buttons pushed. Are you pushing each other's buttons in your study groups, or you're just going through a casebook? You cannot learn this through a casebook. This is about quality, not quantity. I will make my own registrars at St Mary's repeat a case 4 or 5 times until positive behaviours are ingrained and reinforced. And the people that I'm mentoring at the moment, which is about 35 resits, very, very busy on my account, I will make my candidates repeat cases until the positive behaviours are re-ingrained. Now, when we start thinking about time management, you really need to get into that second half at around the 5 to 6 minute mark. You can still do it with 5 minutes. You can even push it with 4. But remember, the clinical management carries 1.5 times more marks. So you do have to give yourself that space to do it. And that all depends on good case priming. The exam starts as soon as you have those 3 minutes. So it's very important to know your place in the journey. The analogy is a car journey. Remember, when you get into the car, the journey's already started. It started in the case notes. So case priming is understanding what has happened before you get into the car. Previous discussions, specialist letters, results, comorbidities. Are they well controlled? Medications, are they being taken appropriately? Blood test results. Any social history. All the time to pass this, you need to ask yourself, Why? You cannot pass by sitting on the fence. If your history has not determined whether something is serious or not serious, if you cannot come down on one side of the fence, if you are dependent on that examination or investigation, it means you failed the exam. You cannot pass. No SCA case is designed in that way. So know your place. And no more is this important than in a follow-up. There are so many terrible, terrible messages out there. Retake a history. Why would you retake a history in a follow-up? In breaking bad news, you can't be assessed on breaking bad news till you've broken it. So in those 3 minutes, use the notes. What's led to the test? What was discussed? But give those results in the second to third minute. You cannot pass if you hold on to those results. It's very, very dangerous. And the ethos really of that day is to really manage the situation. Okay, so this aspect of AEE, I cannot emphasize the importance of positive transference. That is so difficult. Everyone's scratching their heads going, I don't understand why this examination is so difficult. It's not rocket science. It's a communication skills assessment. By default, communicating remotely is tough, you know? Not just what you say, how you say it, your tone, your time, your pacing, all of this can be compromised on audio and video. Top tip one then, use the information provided in the case notes. Understand why it's been given to you. Don't go in blind. Okay, you've got to have a battle plan. I'll teach you a little bit about this tonight, and we'll showcase this hopefully with one of our participants tonight. Top tip two, never park a queue. In a standardized exam, queues can only be given twice. Okay? Never talk about things later, please. If someone's saying, I want diazepam, if you're someone who's like, well, I'll talk about that later, you've already failed the case because what the case is testing you on is negotiation. You want to be curious. Why does that patient want diazepam? What do they know about it? It's about verbalizing the elephant in the room earlier rather than later. The dilemma of giving a controlled drug in someone who may not need it. You don't have to deal with the situation straight away, but acknowledge the situation straight away. Very important. Use ice to focus. Okay, that patient who's coming in with a headache, I want to know earlier whether they're worried about it being a brain tumor. I can use that to center my consultation. The issue here really is that if you are someone who's opening ice only at 6 or 7 minutes, you can't do anything with it. And the great thing about a standardized exam is that every patient will have a component of ice built in, but it's only useful if you use it and then readdress it. If the patient's opening statement is, I want an MRI scan, they've already given you the expectation. Don't over ice, but be curious about the I and the C that precedes the E. No generic or formulaic questions. You will be marked down on this. And this is something that no one's ever told you, but you will be marked down. It's a standardized exam. You see, on lots of webinars out there, lots of people are telling you this, like, oh, it's just a standard clinic, lots of open questions. It's not a standard clinic. There's no golden minute. It doesn't exist in a standardized exam. Tell me more will often be met with what do you want to know? Any other symptoms? What does that mean? Anything I've missed you want to tell me so I can pass the SCA? Well, you've missed plenty. I can't tell you anything unless you specifically ask me. There's a golden 15 seconds. Okay? Signpost questions so they have context. Don't ask smoking and alcohol if they've got nothing to do with what's being talked about. If the patient, for example, is short of breath, signpost your lifestyle habits. Lifestyle habits can be important with regards to breathing problems. I can see from the notes that you don't smoke. Is that still the case? Don't over summarize. You see, that's a really bad message, isn't it? Summaries. Summaries are really powerful in real life because in real life, the patients fill in the gaps. But in a standardized exam, no one's going to fill in the gaps for you. In fact, over summaries highlight everything that you've missed. Okay, so be very careful. It's very important to take the right message in. Reactive risk management. You can't sit on the fence. You've got to come down on one side, serious or not serious. And if it's serious, how serious is it? Is it serious enough to warrant admission? Maybe not as serious as that. Is it serious enough to warrant urgent investigations? And I don't need a diagnosis to necessarily commit to risk. An acute red eye could be acute glaucoma, acute uveitis, doesn't matter. still needs to go to eye casualty. The dilemma will often be that the patient doesn't want to go to eye casualty because there's something in their situation that prevents them from doing so today. And recognize that, if you are going to present something that's serious, that action is going to have a reaction. Don't underestimate the word cancer. Cancer is a big word. It's a scary word. Okay? You put it out there, you can't take it back. So the analogy we teach on the masterclass in terms of risk management is it's a swimming pool. You get into the shallow end and you swim to the deep. The shallow end is readdressing the patient's ice. Mr. Smith, I appreciate you thought it was this, but we just need to keep an open mind, given that you've had some other symptoms. Would you be open to further investigations? For example, if it's PR bleeding, would you be open to having an up-to-date fit test? Now, that's a screening test, just to make sure we're not missing anything else. And the reason that we do that test is we have to consider all causes, one of those causes being cancer. Now, when that word is out there, your patient, they're going to start drowning in that swimming pool. So it's a motive. What do you fall back on? AEE, acknowledge, empathize, energize. I can see you were not expecting to have this conversation today, and I'm sorry, I didn't mean to shock you by it. But firstly, let me reassure you, no one's saying that this is cancer. This is just a screening test. And even if that screening test is positive, it still doesn't mean that you have cancer. So can you handle those emotions that surface in the SCA? Because it's a very, very emotive exam. And that does bring us on to AEE, the glue that holds everything together. Are you somebody who's just going through the motions of going, okay, fine, sure? On my masterclass a couple of days ago, I had a candidate who said, okay, fine, sure, 62 times in 12 minutes, to the point where my simulated patient actually said, Doctor, with all due respect, if you say okay or fine one more time, I'm going to leave this consultation because there is nothing I have said which is okay or fine. To acknowledge, you have to say what you see and mean what you say. You have to counter, anxious energy with positive energy. Think about what you can do to help. And this is the key. Often you won't be able to meet a patient's expectations. If that's the case, it's going to get emotive. AEE, acknowledge the dilemma, the elephant in the room earlier. If it's a negotiation, which it will be for 60, 70% of the SCA, you've got to know how to say no. Here is a ground rule. If someone in the SCA comes in and goes, I want a sick note, I want this referral, I want this to be confidential, I want diazepam. If all you do is give the patient what they want, if they leave happy in your consultation, you have seriously screwed up. You have bombed that case beyond belief. If they leave your consultation a bit disgruntled and you found the compromise, you have smashed the exam out of the water. Saying no is a skill. And if you are not testing this skill in your study groups, then what are you doing? Okay. You have to do it. It's so, so fundamental. So always consider the blueprint when you practice cases. You have to apply objective feedback. If you're not calling this out, then you're just colluding. So we are going to do a very interesting exercise. We've not done this before. I'm going to showcase a RCGP case. You'll have 3 minutes. If you have a blank piece of paper in front of you, that would be amazing because you'll need to make some notes as you would do on the day. We're going to bring up a case. You'll have a minute to look at the candidate briefing. It's an RCGP case, 2 minutes to look at the patient's notes, and then we're going to decide from the blueprint what you're being tested on. And then fingers crossed, we're going to play out an active simulation with one of my ST registrars who I believe has joined tonight to showcase how to score top marks in this RCGP case. Okay, so I'm going to bring up the case and you need to make your own notes. We're going to be running a poll after this. You've got a minute to look at this. Don't sit there passive. You're all going to have to vote in a second and we will call you out. Another 15 seconds, and we're moving on to the patient's notes. All right. Let's move on to the patient's notes. You have the remainder of the time to make your own. There's about 30 seconds left now, guys. Coming down to the last 10 seconds. Okay, we're going to run a poll according to the SCA blueprint and what you think your battle plan is going to map to. Okay? So let me just launch this poll. You have to choose the top 4 things this case you feel is going to test you on. Okay? So let me just go back and I'm going to launch the poll. You've got about 40 seconds to decide. Everyone needs to vote. Got about another 15 seconds, guys. Everyone needs to vote because you know what? You're all going to be in this situation very imminently. If you haven't voted, it means you don't have a battle plan. I want to get it up to 90%. Only 80% of you have answered. Keep going, because if you're going in blind to this, you are going to get stung pretty badly. All right, I'm going to end the poll. Let's share the results and let's see what people have said. What's coming in top? Older adults and urgent and unscheduled care. It's not really about older adults. Urgent unscheduled care. What's very interesting is that new presentation of undifferentiated disease has only come in at 12%. New presentation of undifferentiated disease should be coming up at about 100%. And new presentation of undifferentiated disease always goes with urgent unscheduled care. You have a man with undifferentiated diarrhea who is dehydrated, has a low blood pressure. That always goes with risk management. So new presentation of undifferentiated disease should go hand in hand with urgent unscheduled care. We had some blood test results which showed that he was in CKD. And there are 2 things that are compromising his kidney function. Metformin and candistatin. Prescribing should have come in at 100% also. And then along that should be long-term conditions with his diabetes and high blood pressure. Will this man want to be risk escalated? No, because he has a wife and he's the main carer for her. She has dementia. What you're about to enter here is a situation of risk escalation in a man who does not want to be risk escalated. Now, if you hadn't thought about that in your 3 minutes, if you hadn't got a battle plan together, you're pretty screwed, basically. And if you want to see someone who absolutely bombs this case, watch the RCGP registrar who does this on the website, who has no concept of case priming, no concept of risk escalation, no concept of actually what this battle plan involves. So we did our poll. Let's just teach you a mantra and then we're going to do a live simulation. I teach 3 mantras on the masterclass. This is the most important story symptom system. The story already started in Mr. McLean's notes. A poor passing candidate. A poor passing candidate is someone who does this. Hi there, Mr. McLean. How can I help you? That's a poor passing candidate. Here's a clear passing candidate. Hi, Mr. McLean. It's Dr. Giam. Were you expecting this phone call today? Because I had quite a detailed email from the district nurse. I understand you've not been so well with this diarrhea. Do tell me, how did this all start? Being invested in ice? Well, I can see when the district nurse examined you, this is what she found. Can I just ask, are you drinking enough? Your blood pressure is lower compared to 3 months ago. You mentioned it's concerning you because it's affecting how it's caring for your wife. I can see that you care for her. She has dementia. Anyone else around? Is anyone talking to you about the sick day rules? Are you still taking your medication? That's a clear passing candidate. Okay, they don't chase the symptom. They understand the narrative that's already happened. They use ICE in context and they use the patient's ICE to focus down on the symptom in the system. But your clinical brains won't allow you to do that. You see, your clinical brains will try and taste a diagnosis in a narrative-driven exam. How dangerous is that? AEE, acknowledge, empathize, energize, use ICE, readdress it, understand the situation around the patient. Don't over summarize. Readdress ICE, share, and then get into that swimming pool. Okay. Commit to risk, knowing your actions will have reactions. Countering any nervous energy with positive energy and working through dilemmas. Right. We're going to do this now. I'm going to ask one of my GP registrars, Harmeet, to come on. Harmeet, can you just unmute yourself?
Yeah, hi.
Oh, hello, Harmeet. We have to say a big thank you to Harmeet. We've never done this before. So Harmeet's going to perform in front of 60 plus people and will hopefully showcase how to do this properly. So I'm just going to set up a timer for Harmeet. Everyone needs to show a lot of respect for this. It's not easy. We've never done this before on our webinars. Okay, Harmeet, do you need to look at any other information here or have you got it all in queue?
Um, I think I'll be fine, yeah.
Okay, well, I put up the patient's notes. We're going to set up a timer for 12. I'm just going to shut my video down. It's an audio consultation. Remember, on an audio consultation, you can keep the notes up anyways. Your video always has to stay on, but just because there's so many people here, we'll keep Harmeet's video off and my video will stay off as well. So I'll play the patient and Harmeet will obviously consult. 3, 2, 1, let's begin.
Hi, it's Dr. Graywell here. Am I speaking with Stephen McLean?
Yeah, that's me. Hello.
Hi, were you expecting this telephone call today?
Yeah, no, thank you. I was, yeah.
Yeah, I just got this email from the district nurse today. She came to see your wife routinely, and she was a bit worried about you. You've been not your usual self and been having some diarrhea, and she's
Yeah.
just wanted me to check in with you. How are you doing?
I'm so washed out, doctor. Thank you. No, I've had it about 5 days, and
Mhm.
I just mentioned to the district nurse today that I wanted to try something just to get on top of this, but she said I best speak to you first, really.
Yeah, sure. And did you have anything in mind that you wanted?
Well, I can't get out of the house because of my wife. I mean, she's got the dementia, and I've got some
Mhm.
Imodium in the kitchen cupboard. My wife uses that for her IBS, but I just thought because I'm going to the toilet so often, maybe I'll give that a go. But the district nurse said I best check in with you first, basically.
No, and it's best to check in with us as well. And, sometimes there are reasons that we can use Imodium for diarrhea, but not for all cases. So we'll just need to find out about what's causing your diarrhea and get to the bottom of it.
Yeah, okay.
Did you have any idea why you got this diarrhea?
Yeah, I mean, basically, I can't get out because of my wife. I mean, the only time I can get out is when my daughter's around.
Hmm.
She came down last week so I could catch a football match, but on the way home, I thought I'd treat myself to a burger from a food store, but I wish I hadn't. Just, I think
Oh
it's
dear.
that. I don't think it was cooked very well, basically.
Oh dear. So it possibly does sound a bit like a bit of a stomach bug. And how is
Mm.
your diarrhea doing now?
Well, to be honest, I think it is beginning to turn the corner. I mean, I don't feel as much the urge to go today.
That's good.
But I just thought anything to just take a few days off it would help, basically.
And I know you mentioned your wife's got dementia, and I can see on the notes that you're a main carer for her. And I
Yeah.
can imagine having a bit this diarrhea must have been a bit of a nuisance and sort of looking after her.
Mm.
How has it been? Have you been coping?
Well, to be honest, I mean, it usually would be all right, but it's just my daughter's away now on a business trip for a week. I mean, I've got a lovely neighbour who does some shopping for us, but he can't sit with my wife anymore. She just gets too agitated, basically. You know, he can't even sit 10 minutes with her. I
Oh
mean,
dear.
I'd be fine if I could just get over this diarrhea, basically.
Okay, let's see how we can help you with this. Okay. Now I can see from the lovely detailed notes the nurse had given me, she'd examined you, and it looked like that from her examination you were a little bit dehydrated, and your blood pressure was a little bit lower than your usual. When I can see from your notes about 3 months ago from your routine diabetes check you had done.
Mm.
So just wanted to check, with this diarrhea, have you been drinking water or much fluids in the last few days?
I mean, I do. I mean, you know, I've been laying off the food. I'm just having dry toast, but I am drinking. I mean, my average anyway is about 4 to 5 cups of water a day, so that's what I usually drink.
Okay, that's around about a litre. Now
Mm.
you passing urine.
Yeah, I am, maybe not as frequently, but I am still going. Yeah,
Okay. And then I know, or noticed that your blood pressure was a little bit lower than usual.
yeah.
Are you feeling dizziness or any
Um,
weakness?
I feel a bit washed out, to be honest, Doc. I mean, I was a bit off my feet for the first couple of days, but I'm all right now. It's just I feel a bit washed out with it all.
Okay, that's actually really good. And I can also see that you've got diabetes and high blood pressure, and you do take some medications for that, the metformin and the candesartan. Are you still taking these medications even with the
Yeah,
diarrhea?
yeah. I mean, when I had my check a few months ago, they just said continue your medication. I mean, I know how important it is to stay on top of the diabetes. So yeah, yeah, no, I'm still taking my tablets.
Yeah, and I can see from your diabetes check about 3 months ago, your diabetes was good. But did anyone explain to you about the sick day rules
No, no one's talked to me
with the
about that before. No.
That's okay. We can talk about this today as well because it's quite important.
Okay.
Um, Now, just also checking, you've not had any fevers, what I can see from the nurse today, and your blood sugar levels were normal, which was really good given that you've had the diarrhea, not been eating
Yeah.
much, and your tummy's not painful. Is that still the case?
Yeah, no, I had some cramps on the first day, but I've not had anything since.
Okay. And just to double check, some yes or no questions with the diarrhea. I know that it's getting better now, but just wanted to make sure that you didn't have anything like any blood in the poo.
No.
No, okay. And how has your weight been? Has it been stable?
Yeah, that's all fine.
Okay, and no vomiting as well.
I vomited on the first day. I haven't vomited since.
Okay, that's good. So it actually sounds pretty reassuring at the moment, Stephen.
Mm.
Usually with diarrhea caused by a bit of food poisoning, it sounds like that dodgy hamburger you had a few days ago must have caused it. And usually they do sort of get better on their own.
Mm.
Um, Now, I mentioned now coming back into sort of what we can do. Now, I know that you said you wanted to take some Imodium tablets to sort of help calm down the diarrhea.
Yeah,
But
only because I can't get out of the house, because of my wife. I just
yeah,
thought I might shave a few days off, that's all.
You say you can't get out of the house. So do you usually, who does your shopping for you, or things like that?
Well, my daughter would usually be around 3 times a week, but
But
as
she's
I
gone on
said,
a business
she's
trip.
not away. She's away now for the next week. I mean, she'll be back next week. But I got a neighbour. I mean, he's been very kind this week. He's done a bit of shopping for us. But you can't sit with my wife anymore because she just gets
Mm.
too agitated. She don't recognise him anymore.
And in general, how are you? Do you feel you're struggling with coping, looking after your wife? Because
Yeah,
being
I mean, generally I'm all right. It's just, obviously when you knock down with something like this, it just gets a bit more challenging. That's all.
yeah. And have you ever had any thoughts about potentially getting some extra input with caring for your wife?
I don't know. It's just it takes a long time to get my wife to get used to someone. Even with the district nurse, she's dressing a leg
Mhm.
ulcer for her. That took a couple of weeks before she even got used to it. I still got to be in the same room when she
Mm,
dresses the leg ulcer because when she gets agitated, it just takes hours to calm her down. And it's
mm.
too distressing.
Yeah. And is your wife, is she on any medications for her dementia? Or has she,
No, no, she's not on anything.
and do you know if she's been seen by anyone from the older health mental health team regards for the
No,
dementia?
no, no, nothing like that.
Now, I know that you mentioned wanting some Imodium or something to help slow down the diarrhea.
Mm,
Good thing it does sound like your diarrhea is seem to be getting better, and that's what we would usually expect
mm,
with diarrhea caused by stomach bug, what we call gastroenteritis.
mm,
But I think what the problem here is that you're a bit dehydrated, and I think that's why your blood pressure is a little bit on the lower end, and why you're
mm,
also feeling a bit wiped out. So what I actually would suggest is actually not taking any Imodium because mostly they're caused by viruses, and we would really rather want to get it out of the system. Taking things like Imodium will keep the bug in the system for longer and prolong the symptoms, and that won't make you feel good.
okay.
Um, but you mentioned you're drinking 4 to 5 cups a day, and that's good that you are drinking. But may I suggest that you increase that a bit more? I'd ideally like you to drink about at least 2, 3 liters a day
Yeah,
of
I can do
water.
that. That's not.
Yeah,
Yeah.
good. And also, things like replenishing the essential salts in your body that you'd be losing with the diarrhea. We can do that with some diaurolite. I can send that to the pharmacy.
Well, it's a bit difficult. I can't leave my wife, you see.
Oh, who normally gets your medications for you?
Well, usually I'd get it myself, but when my daughter's around,
Okay. Would anyone else be able to get it for you, like that neighbor of yours that you mentioned, who's quite helpful?
yeah, I'll give him a shout. Yeah, I mean, he's around, he'll do it. Yeah, if you send it over, if he's around, he'll get it today for me. That's
We'll
not.
do that. I'll do that today for you. Um, and then in terms of the medication, now I mentioned about sick day rules. So in particular, the two of the medications that you're on, the metformin for your diabetes and the candesartan for your blood pressure, when patients like yourself are a bit dehydrated because of the diarrhea, these medications can make you feel a little bit unwell. So usually what we recommend is when you do have anything like vomiting or any diarrhea, when you are going to be at risk of dehydration, is to just pause those medications until you're sort of eating and drinking and feeling well again for at least 24 hours. Um,
Is that going to be safe for my diabetes?
yes, yes, because it's only going to be for a couple of days, so it wouldn't affect your management of your diabetes.
Okay, all right.
Yeah. And and then um, the other thing, because I know looking back at your bloods about 3 months ago from your last diabetes check, your renal function, so your kidney function, was just slightly reduced, but it was stable. And I'm just wondering, whether you'd be open to getting some up-to-date bloods done today, especially given the fact that you have had this diarrhea, which seems to be getting better, which is good, but you have a bit dehydrated and just want to make sure that your kidneys are still okay.
Can't come in today, doctor. No. I
Okay.
mean, I can come in next week when my daughter's, but I can't come in today.
And I understand that it's a bit difficult for you to just leave your wife by herself. Um, m- may I suggest, if you couldn't get, say, the neighbor to come sit with
No,
your wife?
he can't sit with my wife.
Yeah,
He can't even sit with her for 10 minutes. I could
that's
do, he can go to the chemist, he can do shopping, he can't sit with my wife.
that's okay. Because I do want to get these blood tests done today, I can ask our lovely district nurse here to come pop by today, see if she can to get this blood tests done. If she could do that for you, would you be open to doing that?
I don't mind. I'm not going anywhere.
Okay. That's good. So I'll speak to the district nurse today and tell her to come by and just do the blood test, and then we should get the test results tomorrow, and we can follow up tomorrow and see and go through the test results with you
I'll
then.
let's just stop the metformin then, is it? Did you say?
Yeah, so the metformin and the candesartan, the
Oh,
blood, yeah.
okay. All right.
And as long as you're, and so I'll call you tomorrow just to let you know what the blood tests are, make sure they're okay. And when you are sort of eating and drinking normally again for 24 hours, and you can restart the two medications again.
Medications. Yeah, all right. Okay. No, thank you.
Yeah, but I do want to say I do feel like things are going in the right direction.
Hmm.
Um, but is your daughter aware that you've run down with a bit of this stomach
No,
bug?
I haven't told her. No, I don't want to
Maybe,
worry her.
maybe it'd be worth mentioning it to her, but I don't think there would be anything to worry about, just in case, for her to be there for you if need.
Okay. No, I'll text her. Thank you. All right. We can have a round of applause or virtual applause for for Harmeet doing that case. So well done, Harmeet. That was good. So, this is a kind of the standard thing that we do with our masterclass, specifically around case calibration, mantras, and then score prediction. Harmy has been on the masterclass. She's done a number of one-to-ones. We've been just working on a lot of different things. Um, I suppose it was a good pass. There's a couple of things that I would have definitely still honed in on this if we were doing our one-to-one properly, which is the case priming. There was a lot of amazing case priming there. I would have definitely brought in the CKD stuff a little bit earlier. So this is the case discussion that you see from the RCGP. You see, the problem with the RCGP is they don't tell you when you watch the cases whether there are pass or fails. They don't give you score prediction. No course gives you score prediction. We're the only course that tells you score prediction based on your performance, and that's what you really want to know. You want to know what your caliber is and how to get better. So Harmy did very well, but I would have definitely said we could have brought in the CKD a little bit earlier, and then specifically be specific about, I suppose, the medications in terms of both the candistatin and the metformin that need to be stopped. If we have a look at the case, they specifically talk about assessing, an acute illness in a vulnerable patient with diabetes on whom his wife is dependent for care. Risk is such a big thing in this, including possible AKI. So this aspect needed to be highlighted a little bit earlier. We did talk about the sick day rules, rehydration, oral rehydration salts. But if we had maybe used that information just a tad bit earlier, we could have talked more about the social support in the long term in terms of carer support and maybe a social prescriber when things are a bit more settled. But otherwise, excellent. Thank you so much, Harmeet. So we're now going to throw this open for the next 10 minutes to any Q&A. This is quite different from some of the webinars that we've done before. I just wanted to showcase what a clear pass kind of looks like for an RCGP case. I'm going to throw it out to you now. You can ask me any questions that you want on the three domains. We'll start with data gathering. Um, if you want to ask the question, you can unmute or you can put it in the chat group, and we'll give it like 15 minutes. So it'll be 5 minutes for each domain. Does anyone have any questions for me on what case priming means and what myths they might have around data gathering? Very happy to answer. How do you manage confidentiality with a third-party case? Very good. Any suggestions for case priming when it gives minimal information? Very good. So I'll answer this question about confidentiality. So confidentiality specifically is going to be around, whether a parent or an allied healthcare professional is calling. If it's an allied healthcare professional, like for example a care home, then there should be no issue with this. If it's a third party, such as, a concerned relative, then you need to have the consent of that patient. And the way that this often presents in the SCA is a patient who is about to turn 16, because 16 is the legal age of consent. So again, all the time you're asking yourself why. If you've been given a patient and their notes stipulate that it's a third party and they're 16, your case priming and your strategy should be, firstly, is your relative aware that you're calling on their behalf? Have they consented to that? Because if they haven't, you can't go into their notes, which is already a dilemma. They can tell you anything they want, but you can't actually go into their notes. Minimal information. This is really interesting. So minimal information is very interesting because minimal information often means that a patient wants something from you. And if they want something from you, then it's a negotiation. Okay. Um, and if it's a negotiation, the word dilemma needs to go hand in hand with that. It's so important. So concerned neighbor, so exactly, Catherine, concerned neighbor, I mean, you can't go into the patient's notes. You can absolutely listen to everything that concerned neighbor has to say, but ultimately you need to speak to the patient in order to progress the management. You can take on everything that the patient rather the patient's friend or relative has to say. Okay, shall we move on to clinical management then? Any questions around this? You must have some questions, surely.
I have a question.
Sure.
Um, do we always have to like include health promotion and prevention with all our management cases?
No, not at all, not at all.
No. Okay, thank you.
What I would say to you is if you're told someone's a smoker in the notes, that again it is going to have some health promotion aspects to it. So often what we see in the SCA is you might get an abnormal result. It could be potentially a lung function test which shows an asthmatic picture or a COPD picture, and you're told they're a smoker. That's got health promotion written all over it. But ultimately, no, health promotion doesn't feature in every case. But if it's given in your case priming, then it's definitely going to feature. Can you make management plans that are potentially very optimistic? District nurse attending to do bloods the same day. Great, great question, Kieran. I would say to you, it depends firstly what resources you have and what time you're doing the SCA in. So I mean, I wouldn't be able to do a blood test tonight, would I? I mean, it's just not going to happen, is it? So be realistic with what you've got. I mean, a lot of our services involve rapid response teams, which are great. Ultimately, with, Steve McLean, I don't necessarily have to do this blood test today. I could do it potentially tomorrow. So hopefully I can get someone to come and see him because the circumstances are such that he can't come to see me. But please don't promise things that are a bit unrealistic, like, MRI scans and, open access, this and that. So don't be optimistic, be realistic. Any other questions about clinical management? If you don't know the diagnosis, any thoughts? Yes, just say, I don't know the diagnosis. So I want to know how you manage risk. I don't need a diagnosis, Catherine, to manage risk. I just need to know whether something's potentially serious or not, and whether it requires to be risk escalated. So there are going to be cases on the day where you really won't know what the diagnosis is, but your history alone should determine whether it requires further risk escalation. And I would just be very honest with that. Um, Honesty and transparency are the only two currencies you can pay with anywhere beyond the SCA, even. So, yeah, you don't need to know a diagnosis to manage risk. Will there often be a second area to get into, the wife's dementia and case? Yes, some of these cases are really narrative driven. Often there is a situational perspective, there is a psychosocial situation that you have to manage. There's a dilemma that you need to work through. Not all of them, but there definitely will be a second or third layer to some of these cases, and that's why it's a very narrative-driven exam. And the queue is the king queen of the consultation. The queue will take you there. We're already told that with Steve McLean, he's the main carer for his wife who's got dementia. Why are we being told that? You have to be curious. You have to be, because you have to manage that situation. So the way that Harmeet, if I, I mean, Harmeet has done this case with me before a couple of times, but I had a one-to-one with a mentee yesterday, and I made that mentee do that Steve McLean case. I think it was about 4 times in a row, and they still haven't got it right because it isn't about the case; it's about the behavior. It's about understanding how to optimize good consultation strategies. So, with this case with the wife and her having dementia, just being really proactive. So even in the second half, you would be, you know, recollecting what's been told to you, saying, I appreciate what you told me today. It would be difficult for you to come into the practice because your wife's got dementia, but can we find a way to get this blood test done? So it's being even more proactive with eyes. What do you advise if a patient needed to go into hospital for rehydration, considering being the main care energy clients? So the word dilemma is so important. It's a buzzword in the exam. It features in your SCA blueprint. It featured in my era 25 years ago. I cannot reiterate how important this word is. You have to verbalize what the dilemma is. You have to try and work through it, but you can't force it. In the SCA, the simulator will try and help you. If a door is shut and it's shut firm, you're not going to be able to open it. You'll have to find another way around. So in this instance, he's not ill enough to necessarily warrant hospital admission, but certainly ill enough to warrant urgent investigations. He just can't get to you. So you've got to find a way to navigate that. Okay, shall we move to relating to others? Any other questions about relating to others? I might start the conversation. Relating to others isn't about being just nice. Nice is very important. It's important, of course, and it's nice to be very important, of course, but it's much more important to be nice. Nice will take you a very far way in this exam, but it's much more important to pass, to be nice, firm, and fair. And it is a balance about the three. Being nice is about saying no with niceness in the SCA. That is such a skill. So if you watch Rumby's interview, one of the things that she really says is all the cases she practiced, her colleagues were just playing horrible, horrible patients. Patients who know what they wanted, not what they need. And you've got plenty of patients out there like that. That's low-lying fruit to practice with. These are the best patients to practice with. Patients who make your heart sink. If you want to pass the SCA, you need to get good at managing those patients. It's all about negotiation skill. Any advice about how to prep the opening question to get to ICE rather than just saying our name and asking how we can help? Yeah. So firstly, what information have you been given? So what you can see there, Tom, is in that last case, we had information. So rather than saying how we can help, we're already priming the case. If you've been sent a picture of a rash, you want to be starting by saying, hi there, Mr. McLean, I've just received a picture of your rash today. Is this what you wanted to talk about? And then opening that up, tell me, when did you notice this rash? And then opening up the ice, any thoughts as to what might have caused it? Do you have any particular concerns? And when you made the appointment today, any thoughts as how you'd like to take things forwards? Often the opening statement might be, I want this, in which case don't over ice, just be curious about the I and the C that precedes it. There's something that I'm teaching on the masterclass more recently, actually, which I'd like to share with you, which I teach a lot of allied healthcare professionals. I teach a lot of clinical pharmacists and PAs as part of the NHS contract. I teach ICE now in terms of LICIF. What does LICIF mean? So there's an L and an F, as well as the idea, concern, expectation. The L stands for the impact that the presenting symptom is having on their narrative, their life, and the F is about feelings, how it makes them feel. And I think if you think about ICE in the context of LICIF, it will make you more holistic, just naturally. So I would really encompass you to think about that rather than just going through the formulation of asking ideas, concerns, expectations. If you finish the consultation early at 11 minutes, do you try and drag it out? No, you don't, because all of these Subra, the SCA cases have been designed to be finished within 10 and a half minutes, actually. So if you're very good, you'll finish at around 10 and a half to 11 minutes. If you finish by 9 minutes, you're probably missing something, to be honest. But 10 and a half, 11 minutes. Just to go back to the clinical management, Maheen asks, in that case, is arranging a district nurse built onto the mark scheme? Would you get marked down for thinking the correct management is sending the patient to hospital? No, you wouldn't. It depends on Um, I suppose the context of what's going on. I mean, in this instance, this for Steve McLean in particular, he will not go into hospital, so you can't force him into hospital. So if you just keep forcing your agenda of going into hospital, then unfortunately it won't happen. There'll be certain cases where I suppose you can hold the risk in primary care for a little bit longer. For example, if you're consulting in the morning, but if it's an afternoon clinic that you're doing and they have to be in a safe place, then ultimately you've got to negotiate that. Um, the correct management plan has to be a reactive management plan, not your one driven by your own agenda. Anything else about relating to others? Okay. So let's just talk through a few kind of, I suppose, cases. I mean, we're not allowed to obviously go into the details of this, but I just want to showcase some of our top scorers and um, what's kind of come through. So, young adult female to discuss her mood. This was severe postnatal depression. Didn't want to be risk escalated. There were some safeguarding issues with her child. Very emotive. You know, who wants to be risk escalated to social services? Nobody. So, how do you sell that in a formative and supportive way? Young adult female with skin rash on his arm. Very interesting one. STI. But he'd been unfaithful to his fiancée. Didn't want her to be contact traced because it would compromise his marriage. Can you negotiate contact tracing? Dilemmas. Father of an unwell 3-year-old child. Very emotive case. Wasn't happy with the care that his child would receive from another GP. Very angry. Again, can you handle those emotions? Middle-aged female requesting treatment for heavy vaginal bleeding. Wasn't expecting to be risk escalated. Quite a shock when she heard she needs to go on to a 2-week wait. Again, can you handle those emotions? And middle-aged female with worsening respiratory symptoms who refused to stop smoking and wanted home oxygen. Negotiation, negotiation, negotiation. Just want to leave you with some testimonials, just about highlighting not me or the course, but really what comes up on the day. So Clarissa, who was a top scorer recently, specifically highlights that there was always some second element to the case. A psychosocial perspective, a dilemma. So really, really important. And you know, the cases that we have done tonight, the case that we do on the masterclass, the cases on the mental SEO consults are high challenge to showcase best passing technique. And I really loved this one from Ola, who was an IMG who smashed his exam with 92, 93. Let me just draw your attention to this word. Whenever I mentioned your buzzword dilemma in a case, the least I got was a pass in both management and relating to others, usually a clear pass, because I remembered how you handled tough negotiations and use your tactics. I'm an immigrant, and when you asked me about my learning needs, it was about relating to others. I learned to improve this and through the videos and the masterclass. And then in addition, this is what I loved, which I think relates to back to one of your questions. Case priming. I used my case notes so well, I was able to predict the challenges coming in from looking at just simple things, family history, age, medications, investigations, observations. And this also applied to the ones with very little information. There is a huge difference between working smart and working hard for this. And if you want to join us on the masterclass, I know some of you will be joining us, then feel free to do so. If you want to get your score prediction, you need to come on as an active participant. Demand is very, very high. But you can have a look at the website. If AKT is still bothering you, I can help you with that too. We only specialize in getting people through this exam. So I'll be sending you some resources by close of the day. Do check your bulk and spam folders for the special offers that come through. Let's just talk about what these special offers are. So the masterclass, only 6 active participants, 18 high challenge cases, so lots and lots of personal feedback, marking and predicted scores. You get also access to the Mental SEA online consults, which is my video bank of simulations performed by me to showcase how to get top scores in all the 3 domains. Our special offers today for you attending, and this will expire in 24 hours. If you're taking it imminently, then it's £30 for 10 days access, which will take you up to February. Otherwise, it's £60 for 30 days access. Otherwise, the normal fee is £85 for 45 days access. That special offer will expire in 24 hours. I'll be sending you an email as to how to book that. It has to be undertaken by bank transfer. Do check your bulk and spam folders if you're interested in subscribing to that. And there are many cases on there which will really showcase how to pass and pass well. So I just want to say thank you so much for joining us this evening. A massive thank you to Harmeet for putting herself up there in front of 60 plus people. Not an easy feat. So well done. Harmeet's predicted score definitely around 95. Fingers crossed. Don't try and control in what comes in through the door. It's all up here, guys. Any other questions? No. Well, 8:15, run over by 15 minutes, but we wanted to do that active simulation. Going to wish you a lot of big love, and I'll see some of you guys soon. Take care of yourselves now. Bye.
Thank you.
Thank you.